My name is Dr. Jim Montie. I'm the co-director of the Michigan Urologic Surgery Improvement Collaborative, along with Dr. David Miller, who's the director. The goal of music is to make Michigan the #1 state in the country in prostate cancer care. We currently have practices distributed around the entire state of Michigan. We have 42 practices representing more than 200 urologists and approximately 90% of all the urologists in the state of Michigan. The first goal we attacked in music was the use of imaging. There's a lot of interest in this. It's recognized as a AUA choosing wisely imperative, in that there's recognized overuse of imaging in staging of low-risk prostate cancer patients. We suspected that there was not only overuse, but probably underuse as well, and most of the indications for when an imaging test was obtained was based on the D'Amico criteria, which is based on the likelihood of recurrence after treatment, not based on the likelihood of a positive imaging test. So the opportunity that we have is to try to do the right thing for the right patients. And one question that is important in all of this is, what's so bad about doing an imaging study, even if it's liable to be negative? Well, we know that unnecessary imaging studies often turn up incidental findings that turn out to be of no consequence to the patient at all. But these incidental findings can trigger additional diagnostic imaging studies or even invasive biopsies, such as liver biopsies or bone biopsies, that can be dangerous. And so there is a downside to doing imaging when it isn't necessary. Corollary of that is, what's so bad about missing a positive study? Well, we want to make sure that we identify all the positive studies that we can reasonably, because if you miss a positive study, you're liable to give the patient more aggressive local treatment than what is appropriate and expose them to complications and side effects that might otherwise be appropriate. So this slide demonstrates the distribution of the cases in the registry by different risk strata. You can see that about 1/3 of the patients are high risk, and the rest of the patients, 2/3, are either low risk or intermediate risk. This slide demonstrates the current use of imaging. When we started off in music, we actually had quite a low utilization for bone scans in imaging in Michigan. With an intervention which was based on discussing it at the collaborative-wide meeting and have the clinical champions bring this information back to their partners in their group, we've been able to decrease the use of bone scan and CT scan even more, and these are certainly the lowest rates in the country. This slide shows the use of bone scan imaging and the positivity. The key thing in this slide is that for patients with low or intermediate risk disease, 17% of the patients received bone scan imaging, and this is probably too many. Only 2 out of all these studies were positive, less than 1%. On the other hand, for people in the higher risk disease, only about 70% of the people received imaging, and that's probably not enough, considering that about 10 to 15% of these patients are going to have a positive study. So this demonstrates that there was both underuse and overuse in the population in Michigan. Similarly, for CT scan, these data are very similar. The likelihood of a positive study with low or intermediate patients was less than 1%, but patients in the higher risk group who should have it done and have a higher risk of having a positive study often did not have it. So what we've been able to do is work with our colleagues in operational engineering at University of Michigan to look at the data that we have and come up with some specific criteria for bone scan and CT scan that were based on the likelihood of finding a positive study. And the variables included in this model were age, PSA, T-stage, Gleason score, and percentage of positive cores. So what we came up with was the imaging appropriateness criteria. And these are all based on these data and the modeling. One should order a bone scan if the Gleason score is 8 or greater, or if the PSA is 20 or greater. One should order a CT scan if the Gleason score is greater than 8, or if the PSA is greater than 20, or if the Gleason T-stage is T3 or greater. The mantra that we want to keep emphasizing throughout this project is do it when you should and don't when you shouldn't, based on these criteria. So if we look at what would happen if we actually implemented these criteria in the state of Michigan, we would decrease the use of bone scan from 27% down to 20%, but we would have 17% of the patients with a positive study rather than 12%. Very importantly, less than 1% of patients would have a positive scan that we would miss, and we would avoid almost 40% of the negative scans that had been done. Similarly, for CT scans, using these appropriateness criteria, we would only be imaging 22% of the patients, down from the previous 27%, but a higher percentage would be positive. And again, most importantly, an estimated 0.4% would not get scanned, but who might have had a positive scan if it had been done. And we would avoid over 40% of the negative scans that had been performed. We have suggested that for patients who should have scanning, we should try to get the imaging at least 95% of those patients. On the other hand, in patients in whom imaging is not appropriate, there still may be 10% of patients or so who get it for various reasons such as bone pain and elevated alkaline phosphatase or high patient anxiety that they really want to have it done. So we realize that the appropriateness criteria are never going to be met at 100%, nor should they be. Again, the concept is try to do it when you should, don't when you shouldn't. We're able to provide reports to the practices. This is an example of one that lists the different practices on imaging when it was indicated, and we would like to have everyone at that 95% range if possible, so we have some room for improvement here. Similarly, this is for imaging when it's not indicated at a practice level. And again, it shows that there are a number of practices in whom there is imaging more than 10% in these situations and shows room for improvement. We can also provide the data at a physician level. And these can be used by an individual practice in terms of understanding the practice styles of each of their physicians. And so we can identify if there are specific physicians who, in this case, are not imaging when it is indicated. Or in this situation, we can get down to the physician level and identify physicians that are commonly imaging when it is not indicated. Again, to stress that there's an opportunity here that's not just based on cost. There are some negative consequences to the patient when one does imaging when it's not indicated. We end up chasing false positive studies and exposing the patient to further imaging, expense, and risk. Similarly, we don't want to miss positive scans, and so we want to keep that rate of missing a positive scan below 1% if at all possible. One of our colleagues mentioned to this that we need to explain this in a very specific way, like he tells his wife, explain it to me like I'm stupid. So remember these imaging criteria. Get a bone scan if the PSA is greater than 20, or if the Gleason score is 8 or greater. Get a CT scan if the Gleason score is greater than 8, or 8 or greater, PSA is greater than 20, or the clinical stage is T3 or greater. Do when you should, and don't when you shouldn't. So I like this motto so much, I've decided to have it tattooed on my forehead so I never forget it, and anyone talking to me can never forget it. Thanks for watching. If you do have any questions or would like any more information, please visit us at Music Urology, or feel free to give us a call at the coordinating center. Thank you.